I'm John Hoffman from NBI. I guess that's obvious. So it's my pleasure to introduce Dr. Stephen Poskar, who's extremely well-known expert in psychiatry and psychopharmacology, and also CBT, very trained in CBT. We go back a very long way. We work together with a lot of our very complex cases at NBI, and it's always an amazing pleasure to work with Steve. And really combine on just dealing with some of the most really difficult kinds of clinical presentations and family situations that one could imagine. So no further ado, we can talk about ADHD. Why don't you kick it off, Dr. Poskar, and then I'll join at some point, and we can all just have a discussion or have some questions and answers
All
kind of.
right. So yeah, I mean, I think we're gonna have plenty of time. It's a small group to
Yeah.
talk, so I'm gonna just try to go through some basic things I think might be helpful. So, I think one question that all of us get asked, right, and want to understand is like, what is ADHD? And that's complicated, right? There's a lot of brain circuitry involved in things like that. And I think one way to enter the conversation is through the questions that you guys get asked, and me and Dr. Hoffman, we all get asked, right? Which is things like, if my kid has ADHD and they're bouncing all over the room, why would I give them a stimulant? Right? Like I don't understand. Isn't that going to make them worse, right? Or the questions we also get from parents, which is, I don't believe you that my kid has ADHD. Because when they're doing schoolwork, they can't focus at all. But when they're playing their video game, they're like locked in. And so I think one way to think about ADHD sometimes is the disorder of kind of understimulation. And sometimes with parents, I'll say, do me a favor, stand right up against the wall, an inch away, stare at the wall, and don't move for 5 minutes and see what it feels like to be understimulated. And if you want to move and if you want to do things. And so, what happens, we think in ADHD is because the brain is understimulated. And by understimulated, it's a fancy way of saying kind of the brain's not releasing enough dopamine and what's called noradrenaline or norepinephrine. And so brain's not getting enough stimulation. So if you feel like you're not getting enough stimulation, you do things that actually will stimulate your brain. Running around, moving around, right? When there's low stimulation, calling out, kind of, and doing kind of behaviors that you're actually trying to stimulate the brain. And that's the difference between, if you're in school in a class and there's 30 people and there's a lecturer, yeah, that's not stimulative to you, right? So you fade off, you start looking at things and things like that. If you're playing a video game, right, the whole way video games are built is to stimulate you, right? So now the colors are coming out, the sound, you're interested in the game, you start releasing dopamine and adrenaline and you can focus. And so, one thing we'll talk about in a second is like with stimulants, right? What are we doing? Well, if the brain is understimulated and they have to do all this stuff to stimulate themselves, well, what if I stimulate their brain with the drug? So now I give them a little bit of a stimulant and it increases dopamine and norepinephrine. And now suddenly they don't have to do all these things. Their brain's getting the proper amount of stimulation, and so those things kind of calm down. So I think that's one way, we can think about ADHD. I think ADHD is interesting because it's a condition that is simultaneously overdiagnosed and underdiagnosed, right? And why is it overdiagnosed? One reason I think it's overdiagnosed is because it has the word attention in the title, right? So because it's attention deficit hyperactivity disorder, right? Anytime somebody's got a problem with attention, someone goes, well, they must have ADHD, right? The funny thing is that every disorder almost in the DSM for attention is actually not only there, but one of the criteria, right? So the criteria for depression, one of the criteria, one of the criteria is problems with attention and focus. With bipolar disorder, one of the criteria is distractibility, right? Lack of focus. Generalized anxiety disorder, right? One of the criteria is poor concentration, difficulty making decisions. And when people have things like OCD and BDD and they're off doing compulsions in their head and all of these things, they're not going to have the best of concentration. And so sometimes people get marked with kind of the label of ADHD when it's not really there. And so, it can be kind of, overdiagnosed in a lot of cases. And some of it's also, when just people are just behaving in a way that we don't understand, especially kids. Why is it under, so I would say it's overdiagnosed, but it's also underdiagnosed. So one reason it's underdiagnosed, and I think probably all of us and you guys really deal with a lot, is that if the kid's smart, he can get by most of his life, right? And part of that I think is because, when you're in grade school and you're in high school, it's fairly organized for you, right? Like, yeah, you got to do your schoolwork, but your parents tell you got to do your homework, when to go to bed, when to wake up, and kind of your life is somewhat structured. And even the schoolwork, right? It's regular quizzes to keep you on task and things like that. So sometimes we just don't realize it. And then the kid goes to college. And now suddenly it's not just doing their work. First of all, they're a lot more responsible for their work. And now they got to do their laundry and figure out where to eat and meet a new social group. And suddenly we see the cracks in the armor. So a lot of times, again, people, underdiagnose it early because, again, especially with really smart kids, they can kind of get by and actually do quite well in school, and yet it's still there. I think, one of the other reasons I think it gets underdiagnosed sometimes is that I think a lot of times when people have more comorbid conditions, sometimes they do, like I said before, solely blame the attention on that. So somebody might have ADHD and OCD, and they might say, yeah, but the reason he can't pay attention is he's got OCD. So it makes perfect sense. So they don't even look to see if there's an attentional component. And OCD is a lot more showy in a lot of ways, right? Like if you have a kid, he's got some ADHD, but he's washing his hand 10 times a day. And yeah, you might be more likely to kind of notice that. And sometimes the ADHD just kind of never even gets looked at. And so uh, one of the things is kind of just briefly just touching on kind of medicine for ADHD. And so, the standard of care for medicine for ADHD for, beyond, since before I was born, have been stimulants. And really, what are stimulants? Stimulants, in a short way, stimulants are drugs that kind of increase dopamine and norepinephrine in the brain. And there are a ton of stimulants in life, and nicotine is a stimulant, caffeine is a stimulant. In the world of kind of psychopharmacology, really stimulants come in two basic flavors. They are either amphetamine based or they are what's called methylphenidate. And methylphenidate is just kind of the generic word for Ritalin. And so every stimulant you see is really one of those two. So, the amphetamines are things like Adderall, Adderall XR, Vyvanse. Those are all amphetamines. And then you have short-acting Ritalin, methylphenidate. Then you have long-acting methylphenidate, which is Concerta. You have the patch of methylphenidate, which is called Daytrana patch. You have Focalin, which is a specific kind of half of the molecule of Ritalin. And so you're really, and there's no real data no matter what anybody says, to support using one or the other. Sometimes I find, and I know people find that sometimes people tolerate the Ritalin-based stimulants a little bit better. A lot of people will tell you that they think that amphetamines are a little bit stronger, but I don't know that there's any kind of real data, to kind of support any of that. But we can't always use stimulants, right? And for a bunch of reasons that you guys, again, I'm sure run into a lot. Sometimes the person's got a big, long drug history and it's just not something we're comfortable with. Sometimes they've been on stimulants and abused them, right? Other times, right, stimulants just cause problems, right? No matter what we do with the dosing, the person can't sleep. Or no matter what we do with the dosing, they just can't get food down. And so, all of those can be reasons. Sometimes stimulants can make things like anxiety worse. Sometimes they can make tics and OCD worse. The big problem with that is it's become kind of like lore that this is just the automatic case, right? That you can't give, plenty of people like, I can't give my OCD patient or my tic patient stimulants. They make them worse. When people actually have ADHD, it's actually usually the opposite, right? Usually stimulants will actually improve the OCD and the ADHD. And one way I like to think about it is, if you can imagine somebody who's got ADHD and they have problems not giving into impulses, right? They can't stop themselves from calling out in class or for doing certain things. How in the world do you think this person is going to be able to control their impulse to give in to compulsions? If they can't even not call out, you're now expecting this kid to be able to do that? And, the other thing is, I give people the example of like, I am much more relaxed when I come home and the cleaning lady has been here and everything is in order. When everything's all over the place, I feel more anxious and uncomfortable. And so in many ways, right, if you can imagine somebody with ADHD, their mind kind of their brain being all over the place. It's kind of disorganized. And when you start to organize that, people start to kind of improve. And in my experience, one of the most common reasons when people come to me for OCD treatment that have failed multiple treatments, one of the most common reasons is they have ADHD that no one ever diagnosed. And when I treat their ADHD, now they start to make some headway in their OCD. And now the medicines for OCD start to work. And it really is, it's one of the top 2 or 3 reasons that I see people don't respond to medicine. So not everybody can take stimulants for the reasons we discussed. So we have other drugs that are kind of like mini stimulants, right? One of them is a drug called atomoxetine, which is also called Strattera. And one is bupropion, which is also called Wellbutrin. And actually, there's another name for bupropion when it was called Zyban and used for smoking cessation. So actually, Zyban and Wellbutrin are the exact same drug. Some people don't know that. They just market it differently. And basically, what Wellbutrin and Strattera do, Strattera is really a norepinephrine reuptake inhibitor. So a stimulant kind of causes the brain to kick out a lot more dopamine and norepinephrine. And basically, a kind of norepinephrine reuptake inhibitor works kind of like an SSRI. It increases it, but not as powerfully. And Wellbutrin's a dopamine and norepinephrine reuptake inhibitor. So Strattera and Wellbutrin can work when you can't use a stimulant. And, sometimes they work well. They are definitely not as strong and powerful. But there are plenty of people, and me and Dr. Hoffman, I can think of like several of our patients who've done really well on them because they couldn't tolerate, they were either had a drug history or things like that, and we've given them, Wellbutrin or Strattera. Strattera is more marketed towards ADHD. Wellbutrin's not really; it's more marketed kind of towards depression. But if you look at the data, there's really not a lot of data to separate one from the other. Sometimes people don't tolerate Strattera for the same reason they don't tolerate stimulants. They kind of get, they can't sleep or things like that. Wellbutrin's a nice drug, especially when somebody does have issues with depression. And you can kind of try to kill 2 birds with one stone. The last drugs that we use for ADHD really are only indicated, only FDA approved for children. And those are called alpha-2 antagonists. And the alpha-2s are drugs like clonidine and then, also Intuniv. And those 2 drugs are, again, they really tend to work for hyperactivity and impulsivity. They don't do such a great job for attentional stuff, which is one of the reasons we don't see them in adults quite as much, because adults often, by the time they're adults, can kind of control that a little better. They're not getting out of their seat as much. They're not kind of, fidgeting as much. And so it can be a good drug for kids, but really doesn't do what we want for attention. And even with the impulsivity and hyperactivity, it doesn't work to the same degree as stimulants do. That's my mini talk. So, Dr. Hoffman, take it away.
Yeah, so it's always great to hear you talk about medicine. One of the reasons we love working with Dr. Poskar is just the ability to, just a sheer level of this knowledge and sophisticated approach, and to make really complex things very, very, I think you can hear that, really, really kind of very understandable, and things that, people often don't bother explaining or don't have. They know what they give a medicine, but they don't maybe explain it in a way or have this kind of just way of looking at things that breaks down to how they really work, what's really going on with things. So I think we can all appreciate that. I know I do as a psychologist a great deal. There are things you can do psychologically with ADHD. They're a lot tougher sell than medication because you have to get someone interested. And this happened with actually a mutual patient of ours earlier this morning, where they were kind of explaining to me why that they have a very strong need that their job, this is the first steps in a career, be very, very joyful, be very, very interesting at all times. And I was kind of fascinated with that because I can't remember thinking that my job was going to be joyful or interesting. I was feeling at the beginning of my career, I was feeling people were going to, just kind of use me for a lot of time and get me to do a lot of stuff. And it never even entered my mind that it would be like of interest. But there was a value placed on it being interested, right? So I think that's something very interesting to talk about with people with ADHD. That yes, you could talk about the neurobiology, and of course that's probably the bottom line with everything, but the interest in things being interesting. And even in that great example of someone standing by a wall, and wanting to move, they do because they want life to be interesting. But if you can convince someone with ADHD, and usually it's better for them to be on some medicine first, that actually they want to become boredom experts, it's actually very, very valuable because they just don't see that as valuable, or the long-term utility of being able to stick with something that's boring. Because they want something to be inherently interesting as opposed to being able to bring interest to it. So that's one of the exercises we do. One of the things we really try to do psychologically with someone with ADHD, if it's at all possible, and sometimes it's not, is to break the connection between, people with ADHD, like like as Steve said, they'll do things that they say they're interested in, and they won't do things that they're just not interested in, or they'll do the things that seem naturally stimulating. We try to get people to break that connection between inherent interest and kind of the interest in just seeing how well they could do to build a skill with boring things, and actually making the interest come from the approach to whatever they're doing. Can they get interested in a noodle? Can they get interested in reading a book there that they would hate to read? In fact, one of my many unfinished books is called 623 Pages of Boring, because I feel if anyone could read it, and it's stories about the psychology of a carrot. I mean, it's really ridiculous. But I feel like these kinds of experiences can really, together with medicine, can actually give some people a lot of different tools. Aside from the classic things you hear about in ADHD psychological treatment, which is often people with ADHD, their minds they're very quick, but their inner voice is often very weak. Like they don't really talk to themselves because they can't concentrate on it. Like they don't actually say to themselves like someone else without ADHD might say, "Oh, I think I'll go do this, and I'll think I'll go do that." They don't self-instruct very well. And if you ask them to verbalize their thoughts, sometimes they don't even know what you're talking about. They don't have that running dialogue of, "Oh, maybe this would be a good thing to say," and that's why they're impulsive. So if you could teach somebody to actually have that self-management, that self-talk strategy, and it is teachable. It's just not done very much. It's very, very important to do. So I mean that's I mean there are psychological things to do. Sometimes you can't you just can't get someone's attention enough to treat their attention in this way. But when you can, these things can really work together with the medication. And sometimes they work well enough that someone just kind of like, well, I don't really need to be that interested. In fact, I'm really interested in that's the patient I'm talking about today. I was trying to get them just to be interested in the type of person they are as they approach boring things, rather than being interested in whatever they're doing. And it's someone with the most, Dr. Poskar will know immediately who I'm talking about when I say this, with the most amazing opportunities in life, beyond belief lifestyle. And it's still not stimulating enough. But that's for very complex reasons. So anyway, that's what I had to say. What do you think?
Yeah, no, the only thing I was going to add, so me and Dr. Hoffman have very, very, very long conversations that would probably bore 99% of the world to death, but we find them interesting. And I think one of the things that Dr. Hoffman talks about a lot, and I think this is where I think one of the problems we have, and happens a lot in therapy, is we look at all these things as different and different skills. So somebody goes, "Oh my God, how am I ever going to get better? You're telling me I have ADHD, you're telling me I have OCD, you're telling me I have generalized anxiety and some depression." And in some way, right, again, I think Dr. Hoffman probably would say, like, you can just look at all of this stuff on of like whether where Dr. Hoffman often says, life is kind of approach or avoidance, or we could say like exposure or avoidance. And all we are kind of in some way on a simplistic level, you could say you're exposing them instead of to anxiety, you're exposing them to boredom, right? That you're having them approach boredom instead of constantly when they get bored doing something else, right? Kind of no differently than somebody would say, oh, if something makes me anxious, well then I got to go the other way, right? And so I think it's just getting people used to kind of not letting their immediate thought or brain or emotional response control their behavior. Because like I said, if you want to get ahead in life, you got to be willing to do a lot of boring stuff.
But families also work against this, the environment. Oh, we have to interest our kids. We have to get buy-in. We have to find something that takes hold of their interest. And actually, they don't realize that they're actually weakening their system by doing that. Actually, if they were really thinking it through, we should, if we as parents are really thinking it through, and me as grandparents now, is let's have a really boring day and learn to have fun doing some. And we used to do this all the time with long car rides. Believe it or not, they didn't have internet or video games when I was a kid. There was literally nothing to do in my apartment, which made you go outside and have to negotiate with all sorts of people, right? But it's just the world has this idea that it's life should be very entertaining, should be like kind of like a cartoon. So there's that aspect of things also, and I really do think of it just as Steve was saying. I do think of exposure. We think of it like with OCD and maybe with different like phobias and things like that. But it's a general technique to have someone learn how to master something in a way they haven't before, so that their capacity, their brain's capacity, can grow to deal with it, and they're interested in learning how to deal with it. That they find it fun when things are boring. Can they be the one who's interested when everyone else is being bored to death, which is an amazing success skill.
So I
So,
have a question along these veins, if it's okay to pop in and ask a
oh,
question.
please.
So I think about this all the time. Like, how has your practice for both of you changed, evolved? How do you do things differently, considering the world that we live in with instant gratification and tech? And like, I'm walking my kids around the neighborhood, and there's a kid in a stroller walking around on a beautiful day staring at an iPad. And I'm like, well, this is this is the exact reason why you should be looking out at the trees, not the iPad, right? Or even those of us who are watching a show and we love the show we're watching, but then like maybe I'm also playing solitaire on my phone because I can. So how does that change the way you do things on both sides, the therapeutic side, the medication side, if at all? And then how do you differentiate? Is this a true attentional issue versus a kid who's grown up their entire life being given the instant gratification of dopamine, information, stimulation, fun? Let me throw everything at you to make you so happy. And then you
Yeah,
don't
you're
learn
talking
how to
about
have those
what I
skills.
would call acquired ADHD, like you might have a mild propensity toward it, but our culture now is creating this. Yeah, I think that's a huge problem. We do a lot of parent education about that they're actually, you're right. They're trying to get their kid placated or interested in a way that only makes them have to be entertained even more and makes them less able to have interest. So they have to give them even more stuff, and the snowballs. By the time they come to see me or Steve, there or both, these things wildly snowball out of control. But again, it's a very hard sell for parents. Because the problem is a lot of them are on the same program and they use all these things to avoid parenting in a lot of ways because it's a lot easier to give an iPad. A lot of them would get angry when we actually call them on this, of course, but I think it's very important to do that. This is actually abdicating your role as a parent. It's kind of putting a pacifier in various parallel forms into using that. Steve, like
Like when you would look at the car window to see which of your favorite raindrops was gonna get down the fastest.
that is definitely better training for the kind of skills that you need to be successful in life, as opposed to get a high score on Glaxon, a video game. I don't play video games. I just made up. So
Yeah. So
it,
I think one thing to remember, right? And I think I sometimes like I get patients to try to be competitive. Often patients don't like to be told what to do and controlled. And one of the things I explain to them, like, and it's important is right, like the phone is designed this way, right? Like they don't care about games, they don't care about anything. They care about eyeballs. And so it's designed to be like, on a simplistic level, a big dopamine, high dopamine delivery machine, right? And part of the problem, and this is where it gets to, and we use different words. We can say like acquired ADHD, or it starts to become somewhat like of an addiction model, right?
mhm.
And what happens, when you get a big rush of dopamine from something like that, right? When it happens really quickly, what happens is if this is your baseline and you watch a video or do something or post something online, you get a big hit of dopamine and then it drops, and then it drops to below normal. That's what we call craving, right? That urge to kind of now you got to do it again to get back up, and then it drops below normal, and you're playing this game. And one of the things I tell patients sometimes is, and I'm going to say this, I'll use my kind of New York language. Do you really want to be like the developers or the app people's bitch? Because like right now, like you're their slave. They know exactly how to get in your head. They are literally just giving you stuff and you're like a rat that they're giving sugar to. Is that the life you want to live? And it's really hard. And it's remembering for them, it's really hard neurobiologically for them, right? To kind of fight that. It's hard for anybody. And, I think also, one of the things is there's an interesting study, which is if you give kind of rats in a cage cocaine, they will just keep using it and keep using it and keep using it. If you give rats that have place to roam and do things and run around and you give them cocaine, they'll try it once or twice and then they'll kind of want to do other things, right? So, what are the other things to do, right? And are you teaching them to be bored? Like I tell my nieces all the time, I say, go outside, and they say, do what? I go, I don't know, play with sticks, right? And so I think if you're not giving kids practice at that, right? So they're not building that muscle. And it's just like every time they're doing that stuff, you're atrophying those things. I don't think that the chemical treatment is very different, but I do think, like Dr. Hoffman said, you really have to get at the whole family. And because everyone else is, because the parents are just as addicted as the kids are.
Yeah, and that's why doing individual treatment in this way is not very effective. It has to really be parenting and family and actually you know reframing the whole thing from feeling good to like we have this thing at NBI. You want to be on team functioning or you want to be on team feeling? We really try to make it very simple but compelling.
But I think again,
But
I
our
think
societies, excuse me, but our society's on team feeling, unfortunately, for me, unfortunately.
right. Well, this is what I say. Look, this is the oprification or the self-helpification, which is every book's about how to feel better, how to be happy, and people just buy them, and very very rarely these people buy one of these books and then their problem is solved. You kind of read a book and try to be happy, and then they get to read another book, and again, I think as Dr. Hoffman said, the pursuit of actually feeling good does the exact opposite, right? So I tell people it's not like it's bad to want to feel good. I understand it. But your goal of feeling good is exactly why you'll never feel good.
Yeah, and one thing we do a lot is try to we just use the idea of like are you looking for little F fun or big F fun? The little F fun of just getting your needs met in the moment or the big F fun of really enduring success. Because people don't often do not notice the difference. And or they see as an accumulation of these little F fun things as yielding some ability. And it doesn't. The only way to build ability actually is to be uncomfortable.
And I think that one of the things, it's now we say it about the phone, but I always had this, I have this conversation a lot with patients, whether it's, again, even before all this tech came out, like watching, coming home from work and watching TV all night, or coming home from work and eating a ton, or whatever it is, using drugs. All of those things are very easy, right? They're passive. You don't have to do anything to get the fun out of them, right? Like you drink a beer, just pour it into your mouth, and suddenly you feel good, right? You play a video game, and suddenly you feel good. Whereas going and making plans with friends and doing things like that, right, requires effort. So I'm a big fan of pineapple. And I always say, like, yeah, apples are easy. You don't have to do very much. You wash it off, you eat it. But if you want a pineapple, you got to do some work. You got to cut this sharp thing open and do all this effort and whatever. But it's really good. It's basically like candy. And so I think it's that same thing of this people do things that are easy and simple and it has immediate results, as opposed to, again, it takes a lot more effort to call a friend, make a plan, go out for dinner. It requires a lot. And so that, what I would call activation energy, the amount of energy required to kind of get that thing started is a lot higher for the more meaningful
And
things.
to actually teach kids and families the value in seeking what are called positive discomforts. There are negative discomforts like getting eaten by a shark. There are, there are negative comforts like everything we're talking about here are things that make you comfortable, but actually don't help you very much. And I guess there's some positive comforts, just like listening to some music, doing something that's kind of neutral. But the real area of change in therapy is the embracing and actually the purposeful seeking of positive discomforts. And once you have the idea that that's what you're doing, like you could go to Publix supermarket down here in Florida, Steve, if you don't know, or down the south.
I'm aware. I'm hip.
You know Publix? Okay, cool. So and they'll cut the pineapple for you, but they've deprived you of the joy of getting at the pineapple. The easier you make things, the less you get out of doing them. But it's a like so we look for like a paradigm shift that we're not looking for easy. We're looking for purposeful, difficult things.
It's funny. Quick silly story. So I remember going to my friend's house when my friend's kids were little, and I looked on like right next to the television. They had all these DVDs, and they had a DVD of Frosty the Snowman, Rudolph the Red-Nosed Reindeer. They had a DVD of The Wizard of Oz. And I was so angry. And I yelled at my friends. I said, "You're ruining your kids." I said, "When I was a kid, you waited all year long for Rudolph. And because of that, right, it meant something. It was a big deal. Once a year, they would play The Wizard of Oz. Now your kids can pop it in whenever they want. You've destroyed it. You've destroyed the experience of it. They don't have to wait. It's just, and I think again, unfortunately, sometimes you have to really fight culture. And it's very hard. I think one of the things you guys all run into, and me and Dr. Hoffman run into, is it's also very hard for families because they say, well, how am I going to do this with my kid? And they're going to go to school and all their friends are doing blah, blah, blah. So if they don't play this video game, they're not going to know what's going on. And kids will, and that's I also find one of the biggest thing parents kind of tell you as their reason for doing this, right? Well, we have to. We don't give them a phone, and every other kid has a phone.
Yeah, I want to respond to something that was said a little earlier about, well, how do you know if they have ADHD? Well, you can have very skilled clinicians looking at it, but I do think there's a role for some objective testing because it is really, really hard to tell. But there are some good neuropsych ways of at least establishing whether this is more likely due to anxiety, this is more situational, or more there's some fundamental skill deficits that tend to be correlated with people who have known to have ADHD tend to have. So I would recommend that. I actually think that it's funny that anytime you go to a doctor's office and they didn't give you like a urine, a blood test or something, or even more things like that, or you would feel like they're being kind of remiss. But somehow in the world of mental health, it seems like a huge add-on or almost like an upsell to do neuropsych testing. And it never makes any sense to me because to some extent you're flying blind. Maybe before they had x-rays, the doctor could just like, oh, I think you have this or whatever. But once they had x-rays, once they have scans, I mean, I mean, in the hands of someone who's well trained, neuropsych testing and knows how to look for things and differentiate syndromes, uh, I think it's extraordinarily valuable to do that as a diagnostic tool.
And I think one of the ways I sell neuropsych testing when I'm trying to get people to do it, because it can be expensive and they don't really understand why it's necessary. And I'll often give them my silly example where I'll say, if I ask somebody what 5 plus 7 plus 9 is, and they don't know the answer, it tells me nothing, right? Maybe they don't know the answer because they don't know how to do addition. Maybe they don't know the answer because they have slow processing speed. And when I'm saying 5 plus 7 plus 9, they're still thinking about the 7. They never even heard the 9. Maybe they have a poor working memory, so they can't add the 5 and the 7 and hold it in their head in order to bring the 9 in. So when somebody's got poor attention or poor this, all we know is a symptom. We don't really necessarily understand what's going on. And like Dr. Hoffman said, is this anxiety? Is this this? Is this that? And so that's the way that's the example I always give them is like, it really helps us figure out why someone's having an issue. Because often when we just talk about symptoms, all we know is what the issue is. We don't know what underlies it, what mechanism does underlie it.
So other questions, concerns, or if you want to tell about your experiences with dealing with families on like, do a lot of your families that come in seem to be people who are on the paradigm of let's bore our kids, let's kind of not give so much, let's make life a little hard? I'm being
Never,
rhetorical. Of course not, right?
never,
Never, right?
never.
And there are people who get really upset when their kids are upset, which, by the way, is a new is kind of new in the world.
Yeah,
So
absolutely.
that
Well, I
doesn't,
see it.
like people can't bear their kids being uncomfortable. But that's why we have to educate them that discomfort is not pain. It's actually, this is the way you can't grow. You can't, if you go to a gym and they label the, 20-pound weight, the 1 pound weight as 30 pounds, you can feel really good about yourself. And, this emphasis on, yeah, well, they have to feel good about themselves. Like, why? Does that sound terrible? I'm kind of in the process of writing a book at this point, and I think they're going to be, the editors are going to want me to change this, but I have a lot of stuff on what's the concept of self-esteem, why it's destructive to people. I don't know if you want to talk about that at all, and why I feel about
I
that.
want to hear you talk about that.
Okay. What is that of interest, Glenda, or and Jen? And I know Amber, you can't talk, so
That definitely is of interest, but I do have one question that I
okay.
really wanted to ask you as well.
Sure.
Dr. Hoffman, when you talked about that weak inner voice, can you speak more to that and how do you help people strengthen the inner voice?
Yeah, when you ask someone with ADHD, by and large, they don't self-instruct. You know how, like, Mike, we go back to Mike and Baum's self-instructional training and teaching people to instruct. They just don't do that very well. And they don't do it. They often, I'm not saying everybody, but a lot of people who are diagnosed with ADHD, they're not having these back and forth conversations. Like extreme people with OCD might do it a real lot, so it's an interesting thing to notice. But they're not having like these conversations. Oh, you think it's good to cut school today? Or maybe I should not be doing this. So actually, we have them actually. I have people try to listen to their inner voice, like just to notice it. So I'll have them like whisper something to themselves. Like if their name is, let's say, Joe. Hi, Joe. Or, maybe I think twice. And you actually literally teach them to have a conversation in their head till they say they can hear it, on with volume, and maybe even speak loudly to themselves. You know, yeah, Joe, I think if you just keep pushing your mom and about this thing, things are you're gonna wind up in your room later. And just have a conversation that helps people who we'd say have good self-control to do the. So you have to think, what do people with good self-control do? Aside from it just having been a habit, they actually talk themselves out of doing some silly stuff, right? More than other people. They talk themselves into doing some good stuff. But you have to have that inner conversation as opposed to just you just going, you're just not really having that processing of life. So it actually is, it literally teach the skill, as simple as that sounds.
Yeah.
It's not something that's done a lot. I will tell
Yeah.
you, with ADHD treatment.
Yeah, I really have never heard that before. I find it very interesting. When you
Mhm.
talk about that inner conversation,
Yeah.
I don't treat kids, I treat 18 plus. Mostly, I would say 90% of my practice is OCD treatment, 10% related disorders or GAD or whatever. And I have so many clients who are in their early 20s who don't have an ADHD diagnosis, they do have an OCD diagnosis. And just similar to what Dr. Poskar said, is that nothing has helped them before. They've seen good treatment providers, they've tried good SSRIs with adjuncts, etc., and still not getting better. And then their ADHD gets diagnosed with a lot of advocacy on my part to get properly tested and diagnosed, and they end up going on ADHD meds. And I can't help but what resonated with me, what Dr. Poskar said of coming home when the cleaning lady is there and after the cleaning lady has been there and there's this order. And then I see such a difference in their OCD. Um, I
Yeah,
just,
it's like being in, if you ever gone to a gym and people say, I spent 2 hours in the gym. So, but really they've been on their phone for 20 minutes, they've gone to the bathroom. They haven't spent much time in the gym. People will say they did ERP, but because of ADHD or other reasons, they're not really doing it. They're
Mhm.
not doing it in a way that they're processing or in a typical way. And I think we assume that every time we do face a fear in ERP, that everyone's doing it the same thing, but we're not any more than when people lift weights or do things. There's lots of ways to cheat on it. There's lots of ways to look like you're really working out when you're not. There's lots of, so I think using some of these, we actually were having, we were doing a little talk on that yesterday here at NBI, that about how to have people have more potent ERP sessions and not just assume because on the surface it looks good that it's actually doing what it's supposed to do. And how can we monitor that more?
Yeah. Yeah.
I'm
And I
sorry,
think,
I have to
I think
run. I have a 12:45, but thank you so much. This was great.
Nice seeing you, Jen.
Bye.
Bye.
I think to what, I think to what Dr. Hoffman was saying, and you were talking about, it's a weird thing every time I read articles about ERP and they say ERP works blah, blah, blah % of the time. That's very deceiving,
It's not
right?
true.
It's not that if you go toward, this is just how the brain works, right? It's if you speak in public for 100 days in a row, it's not possible for you to be as anxious on the 100th day, like physiologically. And it's just the difference. Really, what they're saying is X amount of people did ERP, and this percentage kind of refused to, right? It's the difference between saying, oh, a drug doesn't work because everybody took it and some didn't respond. It's more like saying 100 people were given Prozac, 15 people never opened the bottle, right? That's more like the way, and so I think even that can be really deceiving
Yeah,
when people talk
if
about that.
someone actually engages in ERP and does it really well, how often do they not get better? Like how many times do people do push-ups and not get stronger?
Right.
It's just the way your brain works. And I think so I totally agree with what Steve's saying, that just it's very misleading when people say about refractory cases and things like that. It's just not been in, the way that we would, after working with, so many people with it. It's just not the way I see that it works.
Hmm.
But you're right. One of the things you said on that I think was really on point was that, you see these cases where people are on a high dose SSRI and an antipsychotic and a third drug, and they're on all these drugs because everyone's like, they got refractory OCD, and they're missing that they have ADHD, and no matter what you do, and now they're on a ton of medicine, and now people are going, well, we got to give this kid ketamine,
Right,
right?
or DBS or
Or
TMS
DBS
or
or
psychoservice.
whatever, and
And it's just so it's just because there's maybe a fundamental lack of understanding about that they never really did ERP. You're supposed to fail a trial of it, but they never say you're supposed to fail a good trial of it because they have no way of assessing that. You probably see this in your practice. People say they did CBT ERP all the time, and they really haven't. They've shown up at a session, maybe. They've shown up at the gym, but they really haven't gone to the gym.
or again, when they say they're doing CBT, the person doing it was doing other forms, right? Like Beckian cognitive therapy, right? Trying to go, what are the odds that your fear is wrong? What are and so again, that's also just a problem of language a little bit. And again, I think one of the problems, I would say I have this conversation a lot. One of my biggest pet peeves in psychiatry, at least, is that I can open any journal and I can read any million articles about use this treatment for this, use this treatment for that, which is all great if you know what you're treating. The number of articles that you can read written about how to make diagnoses in this field, they don't exist. And so all these people are treating things, but often they don't know how to do a differential diagnosis. They don't do a full interview. A lot of psychiatrists see somebody for like 40 minutes and think you're going to come up with that's a diagnostic interview. So I think part of it's just the field is really poor diagnostically. And I think that's what caught, and so the number of times, obviously, I'm sure the four of us, sorry, Amber, I know you're out there. The four of us commonly deal with is, right, we get patients with OCD, but nobody diagnosed ADHD. We get people with OCD, but no one ever bothered to notice that they were autistic, right? And so, one of the things I always, me and Dr. Hoffman talk about a lot, anytime I think about a case, one way I think of it when I'm trying to think of diagnosis is, okay, this person has OCD. If their OCD went away tomorrow, would this be just a regular functioning person? And a lot of time the answer is no. And if the answer is no, well, then what else explains what wouldn't be okay, even if I got the OCD better?
Yeah, we use like kind of a subtractive model that if that's how we know we're making a more complete diagnosis, that if this was better, like, and this was better, and this was better, well, the person would be pretty functional. But if at the end of the day, you've done all these things and the person still has a social deficit, well, you have to think of something else.
So true. Thank you. That's great.
But
So,
again, it's not a typical way people think, right?
so I want to ask, I'm going to ask Dr. Hoffman a question because I think this is interesting. So one of the things Dr. Hoffman talked about before is being on team functioning and being on team feeling. What do you do when you have a patient or a family that says, well, yes, we want them to function, but what's the point of functioning if eventually they don't feel good? So are we only getting them to function? Are we still on team feeling? Is the only reason, because I think that's what a lot of people will say is like, yeah, who cares about like if I'm the most functional person in the world and I'm fucking miserable, well, how did you help me?
I mean, that's such a great question. There's so many ways to answer it. Well, I guess the theory from a CBT perspective is that the feelings will change when you change your behaviors. That's one thing. But even if they don't, I think it's because it's so interesting about this whole thing about authenticity. Like, I think it's fine to feel authentic, but why do people think that their depressive feeling is more real than and more authentic than a behaviorally activated positive behavior? Again, it's a judgment, and we try to educate people to value their behavior more than their feeling. In other words, like I just heard a new song, and it has for something I'm writing now, it had a perfect line in it that I don't care what you think or feel. And it's a strange message. It's not that we don't care what you think or feel. It's just that thinking and feeling is like your personal experience, but it's not the way to be effective in the world. But people value that. People would rather feel better than function better because they
Well,
think that their real self is what they feel and think. And instead of and really, especially for people working in OCD, if you believe that your feelings and your thoughts are automatic and involuntary, then why are you trying to? Then it just doesn't make sense to think of it another way. Then why are you taking responsibility? Um, Amber and Glenda, I supposedly maybe this month or next month, my article on mental rituals will be in the Behavior Therapist. And I just take a different look at mental rituals. And luckily, I had the help of Dr. Poskar, who was driving him crazy, and us really talking about like why do people assume their thoughts are behaviors? Where did we get that idea from? We start with a lot of premises in psychology that people tend to believe, like their thoughts can do things, and they're something that they're not. So anyway, my article explores that from, a mind-brain theory, from a philosophical theory, and just kind of a clinical theory. Why is it good for people to believe that? Why is that helpful? So it's a little bit different take on it. Kind of lucky it got published, I think. So because it's really sounds strange to people to talk that way, right?
but I think that is, for me, and I know, I don't know what it's like for everyone else, but like for me, that's just again, like even when I say like, well, you value or that your feelings are more important than your behaviors, and they would say, well, all I know is my experience, and why would I want to be would I want to be the most functional person and feel miserable, which is just a miserable life, or would I want to be much less functional and be happy and feel good? And why wouldn't I choose the feeling? Like again, I think a lot of people think, well, what else am I? Like what else is the point unless I feel something? And again, if you were had me doing, if I was the president of the United States and doing a lot, but I was miserable all the time, is that the life is that a good life compared to? So I guess that's again, I think
Well,
where people,
again, we try to get people away from like redefine words instead of feeling motivated to act motivated.
right.
Instead of feeling confident to act with confidence. To not think of yourself like a car that's quart low on oil. And that's the model people really are taught and really believe in. But when they learn something else, look, I think we all find this when we teach people that it's impossible for anyone to have something personally. That's the self-esteem argument. It's impossible for anyone to say anything personally against you as a human being. It's just not physical. It's just not a possibility. That's not. Once you educate someone about that, or you help them really operationalize some of these things, you just see enormous difference in the way people look at life. If you can get people engaged in these conversations, a lot
Hey
of
guys,
people. Go ahead. I'm
can you
sorry.
hear me? How are you?
Hey,
Sorry,
Amber.
it's like illusion driving behind the scenes, but I just parked.
Hey,
Um, I have a quick question, Steve. I'm just so curious, like with all of the advancements in medications, these days, and this is your best guess, probably not evidence-based, but these days, how frequently are you seeing that advancements in meds are really effectively treating true ADHD presentations versus really needing a lot of that executive function coaching, the healthy daily routines you guys have been talking about for a while now?
And I think again, I think it's always hard to look at each one in a vacuum, you know, and I think this is kind of, you know, I wouldn't give it this similar answer, Amber, than I would give for OCD, right?
Mhm.
When I treat somebody from medicine for OCD, right, there's, you know, there are plenty of people that get better from OCD on therapy alone. There are really none that get better from meds alone. Meds can help lower the volume enough
Mhm.
that they can actually engage in treatment. And so I would say is I think no matter what, people should be doing therapy for their ADHD. I think the medicine can make it a little bit easier to be more organized and things like that. And then that allows them to more engage. So I do think it's kind of like a snowball effect. You know, and I think also everyone's just different, right? Some people with meds have a great response, right? They feel like different people. Other people, I notice a little bit of help. So I think it's different than anybody. I mean, I've treated some people with stimulants and it was like life changing. They were just like, suddenly I could just do everything. But I think for most people, you know, I think it's also remembering that if you have ADHD for a while, you also, these behaviors and these ways of thinking kind of build over time, right? So now you started with ADHD and now you've built this circuitry, right? And habits of how you do things. And so breaking those habits isn't something often medicine does alone. It can give you the ability, but once the habit's been going on for so long, you know, it's like, it's funny. It's like we can get people sometimes to crave nicotine less, and yet you'll still see them putting other things in their mouth, right? So
Yeah.
the nicotine was the start, but now they also have this habit component of just putting something in their mouth. And so I think certain habits of how you do things and live your life kind of compound over time that really require therapy.
Helpful.
Well, part of the issue is people really, because of medicine it says for ADHD, they think it's like the entire treatment. Like that, it would be, you know, it's not one or the other. You know, it's kind of integrating both of these things that, you know, you know, just as you were saying, you know, we know with OCD that medicine alone, it's just not going to do the trick. But a lot of people go into see a psychiatrist and with the idea that the medicine, that they don't really need to do anything. They don't really need to do anything else.
And unfortunately, a lot of psychiatrists don't let them know that that's not the case, right? They go to see the psychiatrist, he gives them meds, never mentions therapy, never says anything. So not only do they believe it, but he doesn't disabuse them of that belief.
Right. Or say that the medicine has to kick in first, you know, as opposed to, you know, which is not accurate in most cases anyway.
And what I often say to people, you know, when I have that conversation, I'm actually probably going to talk about that next weekend at Columbia, is that this concept of saying the medicine has to kick in. First of all, you're setting them up in a really bad situation. What if the medicine doesn't work? And now they're like, wait, now I can't do therapy. What do you mean you can't do therapy? I was told that I needed medicine to kick in, right? So now you've kind of already screwed yourself. And to say that somebody can't start doing some form of exposure without
Mhm.
medicine, it just it doesn't make any sense, right? Like, yeah, maybe you can't touch this, but maybe you can touch something that touched something. Like everybody can do a little, maybe not as much, but to just somehow say like we have to let the meds kick in and we have to do all this, I think it's just really it's A, untrue, but I think it's also really dangerous the setup you're giving a patient.
This was
So
great.
Thank you guys.
before we end, any other questions? And I'm glad, thank you
Thank you.
for talking with us. And
Absolutely.
hopefully we'll
Have a
see you
good one,
at
guys.
our next topics. And if you have any ideas for topics, please just let us know. We're happy to, you know, discuss anything.
Appreciate it.
Thank you. Thank you
Take
so
care.
much.
All
Take
right,
care.
guys.
Bye.
Bye-bye.
So
All
thanks.
right.
Thank
Yeah,
you.
I thought it went well.